Hi everyone. My name is Mathuri. I'm a consultant radiologist in the UK. Welcome to my channel, MS Radiology. Um, the purpose of this channel is radiology education, from medical students to radiology registrars and onwards. I'd like to start off with a series of lectures looking at evaluating fractures on plain films. So, the first lecture I'd like to start off with is an introductory lecture on how to assess fractures on a plain radiograph. So, before we go on to the fracture itself, just want to start off with some basic concepts. So, I'd like to start off with introducing to basic some basic concepts when evaluating plain film, and I like to use this chest radiograph to illustrate this. So various tissues in the body absorb X-rays to a variable amount. Bone absorbs the most amount of radiation, where structures containing air, such as the lung, absorbs the least. So you have bone seen as the whitest structure on a plain radiograph, and you see air, the darkest structure, or black, in a plain radiograph. And you have fat and soft tissues in a varying degree of grey between bone, white, and air black. Some really important concepts. So, when looking at plain radiographs of limbs, it's really important that we look at two views. As if we just looked at a single view, you may miss certain fractures or dislocations. So that's why an additional view is necessary. Also, we have clues on a plain film that will help us identify fractures. So, one of the things that's kind of useful is soft tissue swelling. So, if you focus on the radiograph to the left, you can see extensive soft tissue swelling on the lateral aspect of the ankle joint. Compare that to the soft tissue on the medial aspect. The other clue that's quite helpful is joint effusion. So you can see a soft tissue density in the anterior aspect of the ankle joint. This suggests small joint effusion. These are all clues to help us identify fractures. This is can be particularly important in the elbow, for instance, which we'll look at in another lecture. So, what does a fracture look like on a plain radiograph? Essentially, it is seen as a lucent line. So a fracture is a complete break in the cortex of a bone that extends from one end to the other. So normally, when you've got an intact cortex of the bone, you will see the white line of the cortex. Here, there is a break, so you will see that break in the cortex as a lucent line or a dark line because you don't have any cortex there to absorb the radiation and give you the white line that you would normally see with a cortex. Also, sometimes a fracture can be seen as a sclerotic line or a white line. This typically happens when there is a break in the bone and there is an overlap of the fractured fragments which demonstrate itself as a sclerotic line. So we're going down to looking at the fracture description itself. So just like to go through a bit of anatomy of the lung bone that I've got a diagram of here. So the shaft of the bone is otherwise known as the diaphysis. The ends of the bones are known as the epiphysis, and in between the epiphysis and the diaphysis, you've got the metaphysis. So when we are children, you have what we call growth plates or epiphyseal plates, which are demonstrated as the wavy orange line here that contains hyaline cartilage and allows children to grow. So we can use these terms, anatomical terms, to describe the location of the fracture. So how do we describe the fracture itself? So there's a number of different types of fractures that we can have, and I'm going to go through those fractures with you. So we can have a fracture line that's at 90 degrees to the shaft of the bone, which is called a transverse fracture. Any fracture line that is not at 90 degrees to the shaft, to the long end or the shaft of the bone, is called an oblique fracture. And the other type of fracture that you can get is through rotational forces that cause the bone to break. This is called a spiral fracture, so it's most like a corkscrew. And the bones can be fractured in multiple places, in which case it is called a comminuted fracture. Next aspect is, having described the location and the fracture itself, we want to see if the fracture is displaced. So we can comment on the fact as to whether the fracture fragments are displaced or not. And if there is displacement, we can move on to describe that further. With displacement, we always describe it in relation to the distal fractured fragment. So angulation is used to describe the tilt of the fractured fragment. Translocation describes whether the fractured fragment has moved away from each other, and rotation is when the fractured fragment has rotated along its long axis. And impacted simply refers to overlapping of the fractured fragment. Now, another feature that is important to recognize is whether the fracture extends into the joint. This can have implications as to how the fracture is managed. So we describe whether it extends to the joint itself, and also we describe whether there is a dislocation associated with a fracture. Remember, dislocation refers to complete loss of contact between the articular surface. Even if there's a small degree of contact between the articular surfaces of bone, this is described as subluxation as opposed to dislocation. Open or closed fractures. Generally, you may more commonly be able to evaluate this clinically, because what you're looking for is whether there is a break in the skin surface that is associated with a fracture, which is known as an open fracture. There's clues to this in the radiograph. You may see locules of gas within the soft tissue, which intimates that this is most likely open fracture. Neurovascular involvement, again, this is very important. However, it's not something that we can evaluate on a plain radiograph. I just put this to here just to remind you that when there's a fracture, really important to evaluate to make sure that there is no distal vascular compromise and assess the neurology to make sure that there is no injury to nerves. With regards to children, so in children, you can have incomplete fractures. So the fracture does not extend all the way through the cortex. So these can be described as green stick, torus, or a buccal fracture. Additionally, you can have fractures across the growth plate, which is described using the Salter-Harris classification, and we will review that in more detail in my upcoming lectures. So here you've got a radiograph of the ankle of a child, and you can see in this example you have here a brain radiograph of the ankle, and you see this lucid line here, which is the growth plate or the physis. Below or distal to the physis, you've got the epiphysis, and then you've got the shaft or the diaphysis more proximally, and then you've got the metaphysis in between the epiphysis and diaphysis. The growth plate you see here is a lucid line because it's formed of cartilage, not bone tissue, as this patient is skeletally immature. So I want to finish off this lecture by using two examples and using all that we've learned to describe the fracture that we see here. So these are radiographs of the ankle. We have the AP and lateral view. We can see a lucid line within the distal fibula. So we've got an oblique fracture of the distal fibula, which we can see both in the AP and lateral view. There is no displacement or dislocation, but if you look here, it's extending into the joint line. So this is an oblique fracture of the distal. This is an oblique fracture of the distal fibula, which is extending into the articular surface. So the next example that we have here is that I have a plain radiograph of the hand. As you can see here, we've got a fracture of the fifth metacarpal, which is displaced. You can see angulation of the distal fragment, and the lateral view can be used to determine if there is any dislocation, and you can't see any dislocation. And if you note that in the lateral view, the fracture itself is very difficult to identify. And this goes to my point that I made at the start, is that you very much need two views to evaluate plain radiographs for fractures. So in this example, you've got a displaced fracture of the neck of the fifth metacarpal, no dislocation. So thank you very much. I hope that you found that useful. What I'd like to do is do a series of videos next, looking at particular areas. So for instance, the elbow, the ankle. Please stay tuned, and I'd appreciate any comments. And if you've got any other particular topics that you'd like me to cover, please put that in the comments. Thank you very much for listening.